Good morning, everyone. Welcome, and thank you for those attending live in person. We have a room full here in Sacramento. I appreciate all of you in person as well as virtual. I'm going to be doing Mikhail's introduction. He's right here. Dr. Mikhail Schneider is the founder and chief executive officer of Nightingale Education Group, a mission-driven organization focused on innovative healthcare workforce development across entire professional continua. From certificate programs to graduate studies to reskilling and upskilling through continuing education, from 2012 until 2023, Schneider served as the first president of Nightingale College, a higher learning institution dedicated to closing education equity gaps and creating geographic, socioeconomic, and demographic access to the nursing profession, creating thousands of new nurses throughout the United States. A visionary leader and a registered nurse for about almost 30 years, Schneider has a wealth of management experience in post-secondary education for health professions and healthcare delivery services. He is a published academic author, conference speaker, and guest lecturer specializing in strategic planning, organizational development, forecasting, and management. Schneider holds a Master's of Business Administration Master's of Business Administration degree from the University of California at Berkeley's Haas School of Business. In 2024, he was awarded an honorary doctorate in Nurse Education Leadership and Innovation. Dr. Mikhail Schneider.
Thank you, Rian. Thank you all. All right. Well, welcome to all of you on this rainy, thank you for coming, on this rainy Sacramento day. And those of you out there in the cyberspace, thank you for dialing in. We have many, many folks participating in this today. So a couple of housekeeping things right away. We will have a break. We'll go for about an hour and 10 or so, and then break, and then we'll come back and wrap it up. So those of you in the room, if you absolutely can't hold it, go. Yeah, like be kind to your bladder. All right. Another thing for those of you in the cyberspace, obviously there's chat that's happening, and we are monitoring chat in here. Who's monitoring today? Brianne is, okay. And so if something comes up in the chat, that a question or something like that, or somebody has something new to contribute, then they'll wave me, and you know, I'll answer that. So make sure that, and if there is a question that or something that you absolutely must get out, make sure you float it to the top periodically, because as you can imagine, with hundreds and hundreds of on the broadcast, the chat goes fast. Also, for those of you in the cyberspace, throughout the broadcast, there's going to be questions put into the chat, I guess, and then you have to click on the thing and go and answer it. That's how attendance is monitored online. So pay attention to those questions that will be pinned to the top of the chat, right? Am I correct on that? I think I'm correct on that. Brianna's doing something else, but I think I'm correct on that. All right. And the last thing, look, so this is titled, let's see. It is about the future of the healthcare really system in this country. And we're going to talk about where we are today, establishing the baseline, right? The outcomes that we have today. And then what I really am interested to get out of it, and for you, the outcome that I want you to carry out of it, is that all of you are responsible for the future of it. As a future nurse, or as, you know, a nurse with a higher level of license, you are responsible for it. The changes are not going to happen, you know, through talking heads on TV. Turn it off. Turn off your TV. No matter which channel you listen to, turn it off. It is not good for your health. Yeah? Everybody's with me? Okay, good. Now, but that constantly talking about something and bickering and arguing and doing whatever else is happening is not going to change anything. Doing things actually changes stuff. And when, how many nurses in the United States? Anybody? A lot. A lot kind of describes it. How many? Millions. 3 million. Yeah, we're getting closer. Yeah. Yeah, not quite. We're not quite to 5. So it falls somewhere there. You know, we're probably at about 4.5 all licensees, right? And then not everybody is actively practicing. On the RN side, we're approaching 4 million. Or again, depends on what study you look at, right? And kind of how we don't count very well. We haven't learned basic math, right? Because if somebody's licensed in multiple states, we count them as one in every state, and then we add all of the states together, and they're like, oh, we have so many. So the good answer, the right answer, nobody knows. But it's a lot. So that was kind of, yeah. That was correct. Now, if that a lot actually got involved in driving healthcare, changing healthcare, improving outcomes in the system, we would be so far ahead today of where we actually are. But we, as a profession, are mostly complacent. We show up. We do a really good job for our patients that we work with. And that's questionable too, you know, based on the outcomes that we get. But, you know, we show up, we clock in, we clock out, we get out, and it's like, that's it, shopping now and doing whatever else with my life, and not really, and then wishing and hoping and praying that things will change. Oh no, some nice politician is going to do it for us. Ain't going to happen. Has it happened so far? Have you been all wishing and praying so far? Yes. Has it worked? No. Is it going to work? No. Because evidence suggests that that does not work. Yeah? Everybody with me? So, I mean, yeah, of course, some of you need to get involved, like, and seek office, and perhaps drive it from that standpoint. Speaking of office, up until this last election, there were four nurses in the U.S. Congress. There are 3 now. Nursing represents more than 1% of the U.S. population. And yet, we have 3. There's plenty of doctors, a couple of dozen. Where are we? So think about it, right? Some of you, ooh, yeah, running for office. Yes. So some of you have to. However, again, it's you getting involved that's going to make a change and not anything. For the purposes of today, this is not political. None of what is being shown or said is political. We've politicized absolutely everything in our lives, unjustly so. We'll talk about as we go through it. So please remove whatever talking head hat you're wearing today. From, you know, Fox or MSNBC or whatever, you know, HuffPost, whatnot. Forget about it. Put on your nursing hat. That's what's important today. And then hopefully, you know, like you just continue in that manner going forward. So, yeah, so everybody with me? Good so far? Any questions? Any questions at all? Okay, so let's talk about this one particular word. You heard it in my introduction. Dedicated to closing educational equity gaps in this country. So this is what I do. This is what I chose to do specifically for nursing education. This is what we do as an organization. working on closing educational equity gaps. The word equity has somehow gotten a bad rep in the last, whatever, political cycle. And I don't understand why. I actually do. Nobody understands what the heck it means. We have not picked up a dictionary in a very long time to truly dig into it and see, like, what does it really mean, equity? So my question to you is, what does it mean? Educational equity gaps. Closing educational, let me illustrate. Yeah, go ahead. Hi.
So my understanding of equity is that while we're not physically all the same, equity is being treated equal while acknowledging differences. So like women needs different things in the bathroom than men, but what equity is giving them each what they need in the bathroom.
Very good. And it's not necessarily just about the bathroom.
No.
Right. It is about absolutely everything in life. And you're absolutely right. So it is every individual has access to the resources that they may need, that person, right? Individual person, to the resources that they may need to achieve an outcome that is comparable to the rest. It is about the achievement of outcomes. It is about opportunity. It is about all of that. It is not about anything else. And it's having access to resources. Show of hands in this room. And if you guys can, how many of you have tried enrolling in another nursing school and been consistently told no? Raise your hand. Who? Okay. Plenty, right? Do you see people of all kinds raising their hands? Yeah. Correct? Has nothing to do with the color of your skin. It has everything to do with individually what you need. It has everything to do where you come from, right? It has everything to do with, now, let me ask you this. How many of you think it is inequitable that you in California cannot do your clinical rotations because the law prohibits it in your home state? Where everybody, I see you. It's everybody. Do you have what you need as compared to somebody else to get to similar outcomes? Yes, right? We're sending you out. We're doing all of this. Is it very just? No. So you still can achieve you still can graduate, you still can become a nurse, but the hoops that you have to jump through are much higher than somebody else. So the resourcing isn't necessarily equitable, right? So, yes?
I haven't really dug deep into this topic, but I have heard of it. What are the reasons they're saying that we are not, or they keep denying this bill?
Simple answer. Please. We've offered them a lot for processing applications or whatever it is that the state may want to do. So it is not about that. The reason is anti-competitiveness. That is the reason. Because the school that exists, they control the Board of Nursing. Big players. Your California states and your community college system and all of this. And they say, oh no, because you chose to attend an institution that actually admitted you and is supporting you to graduation and to licensure and all of this, but that is based in a different state. No, the answer is no for you. So that, again, it's politics. That's what it is. It has no evidentiary good reason for it. The state Board of Nursing in this state has been regulating education by opinion, not by evidence, for a very long time. And the evidence that they actually produce, quote unquote, is very opinion-based. They ask schools about their opinion. And that's the evidence that they use, saying that that's actual science. It's not. So, again, right? I don't want to like spend a lot of time because we have people from across the country on the broadcast. But equity is about achieving comparable outcomes, and the outcome here is for you to be able to progress, to graduate, and to get licensed. This is the company that I've built. This is the college that I've built. So to allow, no matter who it is, people that have been forgotten, discarded, whatever, out of the system. You were not good enough. You did not go to a good high school. You didn't get a 4.0 GPA. You're a bad test taker. Therefore, you're going to be a horrible nurse. Nothing can be further from the truth. It is not about the ability to take tests, although those are important to, like, that's how we measure progress. Although we're changing the, like, fundamentally in the future, changing and working on it now of how we assess and what is important and what competencies we develop and so forth. And so it is that. I've been passionate about it for a long time. I came to this country as a refugee. As a refugee, I did not speak a word of English. Not a word. I was poor. I had nothing. When I got that license, finally, after years of living in poverty, it was like the Charlie and the Chocolate Factory ticket. Right? Many of you, I'm sure, feel that. Those of you are out there and whatever. Like, nursing is one of the best socioeconomic mobility vehicles in this country. And yet, the people who it can support the most, it is not available to. It is simply not available to. And that is not equity. So there you go. That's the explanation. Health equity, same thing. Same thing. Having what one needs, access to it. Whether they use it or not, it's up to them. But access to it in order to be able to achieve a comparable outcome to everybody else. Live as long as somebody else, right? If you're talking about big outcomes. So we'll look at the outcomes in a second. This is, by the way, all y'all are going to get the slides, the PDF of the slides. So don't like worry to jot things down. You'll get them after this. This is from the 2020-2030 Future of Nursing report that was published or produced, second of its kind, produced by the National Academies of Medicine. It simply says this: we will never thrive as a country unless we have what we need to live a healthy life. Yep. And no matter who we are, no matter where we live, that's sort of the equity piece of it. Nurses are catalysts for this change. Catalysts can be. Not are, but can be. They are trusted bridge builders who collaborate with people and communities and organizations to promote good health and well-being no matter one's background. Yeah? And for our country to advance health equity for all, the systems that educate, pay, employ, and enable nurses must permanently change. Systems. So this thing that we're talking about in California and inability to enroll in a school and graduate from a school and access clinicals for you all and all of that, that is system that is not set up for success. We're doing the same thing we were doing 40 years ago. 40 years ago. It hasn't changed. Ouch. How many of you were not even born 40 years ago? Yeah, most of this room. So yeah, this is what's needed. It's out there, and we're going to talk about the solutions. Let's talk about the U.S. healthcare system. Oh yeah, and the question is going out there, and those of you who haven't read it yet. Why is health important? Is health important? Absolutely. Absolutely, it's important. Why is it important? Quality of life, right? And when you have quality of life, what happens? You're happier, right, as an individual, right? And then what happens? If everybody's happier. Yeah, people are thriving, communities are thriving. We're not at each other's throats constantly.
Better patient care.
Right, I mean, right, care is there, right? But health itself, right? Care exists to support health, right? That's what it's there for. The entire system supposedly exists to support health outcomes, right? Healthier population. Why do we want a healthier population? Community is better, but what else is better? Economy is better because healthier people, happier people are more productive. There's plenty of studies on that they contribute more to the economic development of their communities. And then by definition, everybody in the system it becomes better off when we are healthier, right? Our system, how's our system doing? So those are some of the reasons why health on an individual level is important, why it's important on the community level, why me as an employer, I'm very interested in my collaborators' health. You all get it, right? And we do a lot to support them in their pursuit of health and better outcomes and creating resources and systems that allow everybody to get that equitable outcome and comparable outcome at the end of the day. So it's a good thing. Health is good. Now, whom should these outcomes be available to?
Everybody.
Do you really believe it?
No.
Well, what if they've done something horrible?
No. It should be.
They're still a human, right? Like, yeah, totally. They are still a human being. And they deserve at least the basic level of, of health in order to preserve their humanity and so forth. So, yeah, this argument that constantly, like, whom should we exclude? And usually the poorer you are, like, we're happy to exclude you, from this pursuit of, yeah, like, everybody gets it, right? That somebody like me, and like, I made it. American dream, hello. Good for me. I'm like, I can access whatever it is I need whenever it is I need. Everybody gets that? Do you understand that most people are not in my situation? Correct?
There's
Go ahead.
Actually, the unhoused population in Portland, Oregon is dealing with dysentery right now due to inaccess to public toilets.
Yeah. So it's systemic, right? The outcomes that we get. One of my favorite quotes. It was 1950s. I don't remember which year. And Edward Deming, he is a kind of a quality improvement scientist and did a lot on allowing actually the nursing process itself is modeled after what, like, Deming's work, right, of the cyclical approach to improving outcomes. And he said this. He said, every system, and I'm paraphrasing here, is perfectly designed to produce exactly the outcomes that it is producing. Every system is perfectly designed to produce exactly the outcomes that it is producing. This shortage of nurses in California, which California always is in the bottom 5 of states in this country. It's the most populous state, and it's projected that through 2037, ongoingly, this is the latest data, the vacancy rate, which is the shortage rate, in the state of California is at about 18%. 18%. That's a lot of people. And that's a lot of in excess. And that's a lot of upward pressure on cost and all of the stuff that happens with it. right? Is it by accident that California is experiencing this?
No.
It is not by accident at all. If wherever you are, whatever outcomes you're getting where you live, not an accident. Absolutely by design. And then the systems that exist, they continually fight any change. Status quo, read up on it. It's a very powerful thing. Every system is also designed to protect itself and to maintain that sort of balance within it, the status quo within it. So systems change is what's needed to drive and the outcomes that we get are by design of the system. So let's see how we're doing. Let me ask, how are we doing in the United States with our health care?
Not great.
Hey, not great and poorly, true. It depends on whom we compare ourselves to, right? If we take a very low income country somewhere in Eastern Africa, we're doing amazingly. We're like winning, for real. If we compare ourselves to the group that we should be comparing ourselves to, developed nations of the Western world, there. Everybody, us. Australia, Netherlands, UK, New Zealand, France, Sweden, Canada, Switzerland, Germany, kind of. This line is the 9-country average. This line is the top 3 average. Us. Winning. Just not in the right direction. Go ahead.
Does it factor in like population and how much more people you have, or is
It absolutely, it's everything designed per capita, right? And so they look at all of this is Commonwealth Fund. They're a nonpartisan think tank. They've been studying healthcare around the world for decades. And so it is adjusted, it's controlled, it's like, I'll show you some more stuff and then it'll make better sense. Yes?
Is it because those countries have like universal like healthcare?
Oh, you gotta go to the punchline right away. Like, what is the difference? So here's what the question was. Is it because all of those other countries have universal health? Yes, that plays a big role in it. And it's not necessarily, not all of those countries have government-owned healthcare. They just have universal healthcare. So this, again, our misunderstanding is the same as the word equity. Our basic misunderstanding of what universal means versus what government-owned means, we sort of combine it into the same thing, and it is not the same thing. But yes, that's a big part of the reason, and we'll as we're going through it, you'll see some of the data on why that may be. This is the spend. This is how much money we spend. This is per capita. Everybody sort of like along this line, right? And this is like what GDP, gross domestic product, right? This is the size of the economy per person, right? Everything that we produce in the economy, milk, eggs, right, well, yeah, if we count eggs now. But nevertheless, there we are, comparatively, right? So we're an outlier. We spend way more per person. That is counted in this country. This is only census-based. That is counted. We spend more than anybody else relatively in the world. This is as a percent of our entire economy. This says 16.5 in the US in 2023. There's new data now that just came out, and I have it later from the CMS that says it was 17.6% of our entire economy. Almost 1/5 of our economy is spending on health care. Everything else that we do here, education and eggs, like it's almost 1/5, and it keeps growing, outpacing constantly the growth of the rest of the economy. and we're not becoming any healthier. I'd be fine with the spend if actually our outcomes were through the roof and we're like, look at us. We spend the most and look what we get for it. That would be awesome. But we spend the most. I'll ask you later how much. Anybody, how much? Do you know? Do you have that answer? How much last year? Yeah, the 2023 is the latest data. How much did we spend in 2023 on health care?
I guess like per person is like average like almost 15 grand.
Right,
Yeah.
14,570. And what does it amount to collectively? $4.9 trillion. You know how we're cutting this and that and whatever, and it's barely saving us a few billion. $4.9 trillion. That is more than any other sector, and it's a lot of money. And I always invite in these workshops for you guys to write a 1 on a paper and then add like 3 zeros to it. And you're like, okay, $1,000, I get it. Like it's I can do good things with, I'm coming to you in a sec. I can do good things with $1,000, right? You all could, right? And then you're like, ooh, 10,000. Ooh, wow, the things I can do with 10,000. And then it's like add another 0 and it's like 100,000. It's like, whoa, when I am making $100,000 a year, and I'm sure some of you are like getting there, I was like, hello, Prada shoes and a house and like whatever it is you like. Yeah? Touche. Eggs. And then, right, you add another, start like keep adding zeros to it. A million. You sort of see what million looks like. It's a 1 with 6 zeros. Yeah? That's a lot. Holy. If you have that by your retirement, wow. Keep adding zeros. 3 more zeros. What does it make it? 1 billion. Add 3 more zeros, it's 1 trillion. We're at 5 of those. Getting the outcomes that we're getting. Back to you here.
If we're spending 16.5%
16.5% of the
in
economy.
healthcare spending, then where is this money going? Because there's a lot of patients that still have access problems. They're not able to-
Very good. So the question is, where is the money going? I have slides on that. Hold on. But before we discuss that, this is another way to slice this is a 2021 data, but it slices sort of like where we spend exactly, right? So inpatient and outpatient care takes the most of it. And then, again, you'll get the slides, so and all of the references are there, so you'll be able to go and actually dig deeper if you would like. Yes?
I just want to throw out a statistic. So $1 billion is equivalent to 12 days, and $1 trillion is equivalent to 31.7 years.
Right. Yeah. Of what?
Of seconds. Like, so if for
Oh,
12
oh.
days, you would need...
Right. Oh, yeah. Comparative, like comparing the two things. Yeah, exactly. Gotcha.
12
That.
days versus 31.7 years.
That's a good sort of comparative way to look at it and see like, whoa, yeah.
I didn't know what it was before, and then I saw that, and I was like, that is like drastic. Like,
That's a lot. It's a lot. It is insane. It is insane. We should be focusing on that, really, as a country now, right? Making sure we have enough nurses. The nursing shortage today, 2025, the very most conservative estimate, meaning the least we're missing right now is 250,000 across the country. RNs. 250,000 we're short. Some other estimates put it today at as many as 400,000. It's projected by 2032 we will be short 1 million. The way we're going and the way we are not allowing people to go to school where they live. And that plays a huge role in how much we spend. We spend on travel, the outcomes, right? The nurses that are in the workforce now, it's a really tough job. And getting to it all and making sure that you're like you deliver on the outcomes, you facilitate the outcomes that the patients need, is very, very tough. And then and it costs a lot because there's readmissions and there's all sorts of stuff that happens that costing us more and more and more and more. So the shortage is one of the biggest drivers for outrageous spending that we have and not getting the outcomes. This is healthcare system performance compared to the spending. Everybody clustered over there? Us. The highest spending, the lowest outcomes. We face most barriers to accessing care and affordable care. Everybody, us. Equity, us. Cost-related problems. 27% of people in the United States who have higher income report access problems due to cost, 27%. That's the highest number for low-income populations in other countries. 50% of lower-income populations report problems related to access problem related to cost. People cannot afford it. But maybe we should exclude them. I mean, hey, they're poor. Yeah, no? Kidding, everybody. Don't like slice it out. I was like, look what Mikhail said. Let's exclude poor people from I know, from healthcare. Skipping care due to cost. This is the first column is consultation skipped. The second column, diagnostic tests skipped, and the pink column is the prescribed medications or treatments skipped because of the so 23%, right? And we wonder why we don't get the outcomes. So a sliver of bright news when somebody actually has access. Our care delivery system isn't bad. Right? We're rated actually among the top. So the design of it is all right if access is addressed. Now, shortage contributes to the lack of access. Yay, outcome, big outcomes. We live the shortest lives comparatively to everybody else. Our life expectancy, that's us, bright green. This dip was COVID. Everybody dipped. We dipped the most during COVID. So I got rid of some people, you know. Again, kidding. And it's again, for all of everything that we have, it's really sad. Avoidable deaths. Everybody reduced quite a bit over the past decade or so. We're barely scratching the surface of reduction in avoidable deaths. Avoidable, fully preventable. As a matter of fact, we're doing a horrible job. This is the one thing, you know, the new Secretary of Healthcare, HRSA, and I agree on, is that there's not enough promoting of health. There is not enough prevention of the disease. There is not enough effective chronic conditions management in this country. There is not enough. There's so many nurses, and yet we're nowhere to be found when it comes to that, right? So pay attention to how and what you learn. Years of life lost, you know. There's cancer, heart disease, transport accidents, accidental poisoning, intentional self-harm, suicide. Highest from anywhere else. As a matter of fact, I'll give you this, firearms, death related to firearms, both self-inflicted, which you don't hear about a lot. You only hear a little bit when it's, you know, a mass shooting or something like that. But it's the leading cause of death for people between 10 and 19 in this United in our country. Death by firearm, 10 to 19. Horrible, horrible outcomes. Oh yeah, winning here as well. Developed country, we rate about 47th in the world in our ability to protect the mother's lives during pregnancy and childbirth. Horrible outcomes. For black women, this number is 55. 55 in this country. 55 women die for every 100,000 live births. In a developed world, that is an absolutely unacceptable outcome. Adults with multiple chronic conditions. See that number? If you count everybody who has at least one, we're approaching 50, we're over 40% of the population and ticking upward. Chronic conditions. Yeah, everyone was like, oh, Mikhail, you're killing me. It's like, lighten up the mood a little. We will, when you're going to start contributing on how you fix all this, you all. Obesity rates, 40%. A little bit better than the average right now is 42. That's the average number across the states, 42%, or US population. 42% of population, and probably now, we'll talk about this a little bit later, with the introduction of drugs like Mounjaro and so forth, for weight reduction, it likely is to improve over the next couple of years. We probably will start seeing better numbers in this thing, but nevertheless, California, with the 42 average, California is at about 37.6. So doing a little better than average. Yay, California, yay. The highest is West Virginia with 51% prevalence of obesity. 51%. Yay, fried goods. Okay, so there's another question going into the chat. But this is the summary of it, and like the sort of so you see it on the same slide. We rank the worst in all of the big health care system outcomes. All of them, not one, not two, all. Again, the slides will be shared. So yes.
So you talking about all of this all falls on educating people in health, because
Educating people in health. Yes.
we lack education.
Correct. So our system is not set up, right? We've been talking about, and again, I'm waiting to see what happens. I don't necessarily agree with RFK on his stance on vaccines, although he rolled it back a bit. But I do agree that in order to get to, we need to produce way more healthcare providers, workers, practitioners, right, nurses, in order to be able to do it, to deliver that education to the population. We need to, you all, right, what can you do to educate the population? I mean, think on that for a second, and we'll come back to that. But the health promotion, prevention of disease, and effective chronic conditions management. We must have those three things within the system in order to improve the outcomes. Must. It is not going to happen otherwise. And we have very, very, very little of it. The likes of Kaiser Permanente here, that's been sort of their thing for a while. So they do get comparatively better outcomes because they focus on the front end way more than anybody else as a closed kind of like payor provider system. But that's like very, very few, right? That I mean, doesn't begin to scratch the population of the United States. And so there are answers out there. 4.9 trillion per capita. It's 14,000 bucks. That's a lot of dough. Yep.
The average for other countries is 6,600.
Yeah, 6,600 average for others. We're more than double, and again, per capita, and we get much worse level of the outcomes. This is sort of like just a quick breakdown on who pays for it, right? Who funds Medicare? Who is the government?
We do.
We do. Taxpayers do. Yep. Taxpayers do. If you work, you fund Medicare. Who funds Medicaid? We do. This is, so private insurance, we'll talk about that later. We fund part of it, right? We fund part of it through our like copays and premiums and all of that. And then who pays out of pocket? We do. Yay! All right. This is out-of-pocket spending. Us. This is household out-of-pocket. Some other countries, most except Switzerland, spend less out-of-pocket. But we, again, do not confuse the fact that this is shorter than Switzerland. You pay most of it. We do pay most of it. Should we be demanding better outcomes for what we pay? I think so. Get involved. Get involved in a political process. That was the question, I think. So this breaks it down a different way, right? So private business, about 18%. The other private, that's foundations and associations like nonprofits, non-governmental organizations that pay. So about 25% doesn't come out of the taxpayers' pockets. The rest of it does. The rest of it does. So if you think the argument always, sort of like I saw back in the day, Affordable Care Act, when that was kind of being debated, the Obamacare thing being debated, like people literally were demonstrating on the streets with the signs that read, "Government, hands off my Medicare." Government, hands off my Medicare. Medicare is government. It's like, so the fact that we absolutely do not understand, the reason I do this with you in the very early on to your sort of nursing school career or whatever it is that you're pursuing now, is so you understand these nuances. And again, and my invitation to you, please turn off that TV. Oh my word. I was like, TikTok, let alone, but I was like, not good, not good. So taxpayers pay most of it. This is the latest data, and 2024 should come out in a few months, but we'll see how are we doing. So this is the sponsorship, and this is where the dollars go. $1.5 trillion goes to acute care. What do we treat in acute care? Tell me more about acute conditions.
Like a fracture,
Fracture, yeah. So the system, as a matter of fact, initially the acute care system was set up to treat truly acute stuff. Like, I climbed a ladder, oopsie, I fell, I broke my leg, fix it. Oh, yeah, you go to acute care. Yeah, they set some, screws in there, and it's like, okay, good as new. What else? What else was like back in the day? Like when the acute care system was designed? What else was like acute problem back in the 50s? Probably not as many. But what was acute? What was the biggest acute problem? No. The biggest acute problem, let me finish the question, after World War II. The what? Gunshot wounds. No, not like that. No. We didn't have as many guns back then in the 1950s on the streets. What? Oh no, not PTSD. PTSD is a chronic condition. Childbirth, thank you. Babies were the acutest problem we had. Ever heard of baby boom? Yeah, it's happened then. The old system couldn't handle it anymore because there was too many. So we had, prior to that, it was more kind of like, midwife at home, doula kind of things and so forth. And then it's like, oh no, too many to handle at home. Let's build a nice building and put them all in there. And like a little efficiency in, running from one room to the next. So the system was really actually built to treat truly acute issues. What ends up there today, mostly? Untreated chronic or poorly managed chronic conditions. Absolutely. This is what most of the $1.5 trillion goes toward. Poorly managed chronic conditions. I mean, there's some acute stuff in there as well. Most of it, poorly managed chronic conditions. It's a lot of money that is wasted. We should be doing it much sooner prior to something exacerbating to the extent that needs acute care. Much sooner. And go ahead.
Some people only have access to emergency.
Correct, right. So it's the system design. I'm not necessarily saying, so what we're doing is we're identifying, I'm glad you're thinking, some of you are thinking of why, right? Like why is it? You're absolutely right. Some people, especially people in low incomes and uninsured folks, which was one of the slides, right? And underinsured folks, they only truly have access to emergency. Right? And they go into the emergency with everything, right? But that's a very quick, episodic thing. We fix it then, and then we send you on your way, and you're like, do better, eat better. It's like, for real, I'm like, TikTok is not good for you. It has created, your brain is addicted to it. It is not good for you. Stop doing it. How effective is that?
Worked good.
Worked. Well, good.
Deleting it now.
Good for you. Maybe for one. Maybe for one. Right. It doesn't. It doesn't. So our thing of discharging somebody from acute care, even if we got them to where they need to be, and then telling them to do better, you just do better. Go and eat better. Eating better, what does it require? Money and guidance of what is better, what is not better. How do you know? Right? There's an example of, here again, like I have another example. Southern California, I don't remember where exactly the place was, but Inland Empire or somewhere. So there is a predominantly Hispanic community and a school there, primary school. They decided to do an experiment with Kaiser, actually. And they said, hey, we're going to serve kids for a while, kind of, and sort of do it this way and that way, whatever, edamame. Right, like some of you are like, what the heck is edamame? It's a bean. It's a pod, it's a bean that is used quite a bit in Asian cuisine. And very high in nutritional value, very high in protein, and very, very cheap. Frozen edamame, cheap. Cheap to produce, cheap to buy, all of this. And so what they learned is that after a while, I don't remember exactly like all of the facts of it, but after a while of doing that, Kids went home and they're like, hey, Mom, I want at a mommy. And Mom would look at them and go like, at a what? I'm your mommy. Right? Anyway, that's my own joke. That wasn't that wasn't in the study. But parents then were sort of encouraged by the kids to change some of their nutrition behavior, right? And become healthier. And then they did measure the sort of over time the health outcomes, and they were better. They were better. So again, but just sort of telling somebody go do better, that doesn't work, right? Like, what can you all do about it? Educate. Like, again, you have to, right, decide for yourself that this is in my community, it's my responsibility. Whether somebody is actually like compensating me for it, maybe it's outside of your main job, right? I'm applying for a fellowship in the American Academy of Nursing, and the only thing they want to know, what are you doing outside of your job? That's what you get it for, right? The recognition. And so the what are you going to do if it doesn't, if it's part of your job? Oh my word, like if some of you actually work in community settings and work with the populations and work in like long-term care and work in home health and all of that. Wow. I'm like, please do, because it absolutely is needed, and that'll be your job, right, to drive that. And then you, outside of your job, you run for office. But it is up to us, with again millions and millions of nurses in the States, and our outcomes, right? We are the most respected profession, and there's poll after poll after poll that says that. And we beat ourselves in the chest, and we're like, oh, look how great we are. Can be greater. Yeah. We can do more. We can achieve more. We can have better outcomes for the populations that we work with, and so forth. Okay. The rest of it you see there, drugs, prescription drugs approaching $500 billion. Yeah. Actually went up quite a bit, the rate of growth. See how it grew by 11.4%. Why do you think in 2023 it grew so much? By 11.4, where everything else is, I mean, hospital care as well. By the way, all of the growth that you see for 2023, it is not because of pricing. Not because of pricing. It's because of utilization and intensity of care. Intensity constantly is going up. And the more intense the care is, you understand that, right? The more expensive it is. The more intense it is, the more expensive it is. It's just fact of life. But why do you think that's the highest number of them all, except, you know, the professional services there, but 11.4%? Yes?
Could it be the increase of GLP-1 use?
Very good. So what got approved?
Wait, what did she say? I didn't hear.
GLP-1 use. What got approved? Exactly. This is when the FDA, prior to that 2022 or whenever it happened, like I haven't looked that up, but prior to that, approved drugs, again, that were designed for diabetes treatment initially, GLP-1s, and approved, and now approved different, like a few manufacturers of those drugs for weight reduction, for weight loss. I know personally people that, there's several folks that work for us. There's a couple of folks in my family that have been doing it. And I saw my brother-in-law the other day, and I go like, where are you? It works. It's pretty incredible of the effectiveness of it. And obviously, you know, the longer term, who knows? Right, I like that, but for now, and those treatments are expensive, and so most of the increase that happened in 2023 is related to those drugs. So, all right, that's where the dollars go. Now we're going to talk about, let me see what's next. I forget. And we're going for another about 10 minutes. Oh, yeah. This one is a fun one. Waste in the U.S. healthcare system. Waste. See those numbers? And these are all. This is 2019 study. Back in 2019, it was estimated as high as 935 billion, or as much as 25%. 25% now is $1.2 trillion. I mean, you can hire a lot of park rangers for that. I can tell you that. We're in Utah, and the toilets are not being cleaned and all of that because they all got fired. And we have some of the best national parks in the country. And so that's sad, but yeah. We can find money. It's just we're looking in the wrong places. So waste, failure of care delivery. Still, although we rate pretty well, there's still quite a bit of waste in that. What does it mean? Failure of care delivery. Not necessarily transport. No, go ahead.
I mean, I speak from personal experience. I had a condition, and I went to the ER for it twice, and they didn't find it twice.
Yeah.
In fact, a nurse diagnosed it on the phone.
Yeah, there you go. Yay, nurses! We're good for many things.
Cost my insurance. One of them cost my insurance $12,000.
Yeah, exactly. It was very expensive. So that, right, when we don't catch something, or when we don't connect the dots together, and so the diagnosis is there, but perhaps we have one nurse because of the shortage where there should be three. Right? And then that poor person, I mean, again, like I feel like thank you all for choosing this profession after all of the horror that you saw on TV about 5 years ago when COVID hit. It is a heroic profession, especially now, especially during the shortage, right? A lot is going to ride on your shoulders. Now, you building resiliency, right, and pushing forward and staying calm and taking care of your bladder. Yes. Yeah. Your bladder first, your patient second. Not otherwise. Not like nobody needs to treat you incontinence when you're older. It's going to cost us. We would like to prevent it. So failure of care coordination, right? This is related to universality of the system. We don't have it. And coordinating between different doctors. My mom, bless her, I love her. When she doesn't get the right answer, that she thinks is the right answer, because her primary care says, hey, I told you, you must lose some weight. It's not very effective. And my mom's response to that, she said, oh, she should look at herself. Which, I mean, she has a point, right? Like, do what I say, not what I do. Is not an effective way of facilitating or educating or doing anything like that. But, you know, besides the point. So she's like, she goes to others, and because it's not coordinated at all, and she's on Medicare and all of this, and she's like, hey, do you have a better answer? And they don't know she went already, you know, and like the diagnostics are not there, and nothing is communicated across providers, and so you have some ways there. Overtreatment. You know how you show up sometimes at your doctor's office, like my mom is like, give me a pill, fix it. I was like, dear, it's not a pill. But the doctors have exactly a minute and a half with you, and what happens? They're like, oh my God, just here. have a pill. Perhaps it'll make you feel better. No, it's going to create a bunch of side effects, and like beside the point. So pricing failure, that one, you know how you shop on Amazon? And if it's like 2 cents cheaper from a different seller, you're like, that's the one. Yep. Guess what? Pricing differs constantly for the same thing, with the same quality outcome. Tremendously. So I have a few years ago, I needed an MRI like with contrast on my shoulder. And the first price I quoted was over $2,000. I found somebody who did it at less than $500. Same procedure, same outcome, same all of that, right? We don't price shop, and so the pricing failure is a part of this. Fraud and abuse is obviously there. And this last $285 billion, administrative complexity, what is that? Why? Why do we waste that much? Close to $300 billion on administrative complexity. What does that mean? Billing, yes, coordinating between all of the providers and all of the payors, which universal systems don't have that issue because it's central. The coordination of it is central. This when everybody has to hire some people to communicate with everybody else individually, negotiate individually, do all of these things individually, it becomes unbearably expensive. And it's a waste. It's absolute waste. So out of the 4.9 trillion, if we did better and cut half of that out now, 600 billion, the needle will move in the right direction. It's not going to happen by a miracle of any kind. Yes?
Yeah, I just wanted to share a story based off of what you said. I don't know, I'm sure a lot of people heard it because it recently happened, but this guy shared a story how he took his child to the emergency room. This just I think it was last week. He took his child to the emergency room. Initially, they didn't have their insurance card, so the hospital billed them.
Yeah.
When he got the bill in the mail, he then submitted his insurance card, so then he got a second bill. Well, the second bill was higher than the initial bill, and then, so he calls the insurance company. He's like, what's going on here? They're like, oh, we gave you a discount since you didn't have insurance. He's like, well, go back to the discount. And they're like, no.
Exactly, we can't do that, exactly, because they have negotiated a contractual price with that insurer, and there is nothing they can do. So yes, that example that I had, I paid $475 out of pocket, and I'm on a high deductible plan, so it would have costing me $2,500 if I went like the entire thing. So, but I didn't use insurance. I paid out of pocket, and it was cheaper, like 5 times cheaper for me. So yeah, I mean, like that exists all the time, right? The system design needs a lot of sort of reimagining, rethinking, rehauling. Before I let you out here, let me make sure. Okay, fantastic. So let's take about 15 minutes or so. So be back at, or like ready to go. We're going to start the broadcast 25 after the hour, whatever time zone you're in. Fantastic. Well, welcome back, everybody. Sorry for those of you in the cyberspace when I got beyond this magic line that appeared during the break. I got blurry. So those of you out there, you all guys, this is as far as I can go. Apologies. But let's continue. But before we do, there's a couple of questions from the chat. And, oh, where's Brienne? Oh, there you are. Okay. Tell me.
Okay. First one is, how are we supposed to promote the health and education with so many political restraints and shortcomings?
That's a great, I'll pose that question for you, right? Because it's an important question to, it's an important question to ask. How can we change anything? Sort of, I'm paraphrasing here. When there's so many sort of political headwinds, and how do we, and it seems overwhelming, and I can imagine, right? Like living today is overwhelming. It's overwhelming for everybody. Now, I'll give you, and this may be an invitation that nobody ever extended to you. But I'll give you this. This is what I do. I constantly ask myself a question: what is in my control? Tell me this: what is in your control? Learning, right? Which is a product of you. We don't learn for you. We facilitate it for you, right? But learning is what you control, right? Learning. You control. What else do you control?
Our communication to others.
How you communicate to others. What else? Time. You control your time, right? You manage your time. You do all of this. The bottom line of this is that the only entity in your control is you. Those of you with kids, you think you control them, and you're mistaken. Some parents are like, oh, I'm going to tell them what to do, and they're going to do it. Nope. They won't. So you're not in the control. You can influence many things, right? But you influence things by doing certain things, like communication is important, how you show up, how you communicate with somebody, how you engage with somebody, how you look at somebody. I mean, like, those things are important, and they are in your control. So learning those tools it is important. Now, so what is in your control when you show up in this political system today? What is in your control? What can you do? Yes.
Advocacy.
You can certainly advocate, right? You can go to a town hall of some sorts, right? Political town hall, and you can say, hey, here's my thoughts, right? And do it not in a screaming on top of your lungs kind of thing. That is not effective. That is not an effective communication. You use evidence, right? And you advocate. And evidence. Now, what you've seen on TikTok or TV or whatever is not evidence. Everybody's with me? A bunch of stuff that you hear isn't evidence. It's not real. All of this stuff. Now, look, media. Media is designed, by its design, to generate money. Bless you. Speaketh the truth. To generate money. That is what it's designed to do, whether it's TV, whether it's any kind of other media, anti-social media, like all of that. It is about generating revenue. So whatever you're gonna buy with your clicks, with whatever, with your tuning in, you get riled up. You tune in TV and it's like, oh yeah, agree, I agree, yeah. My people great, everybody else horrible. Yeah. And they're like, cha-ching, 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 cha-ching. It's entertainment. Entertainment that is not good for your, health. But it's entertainment. And what, like the story, the highlights reel of stuff that you get through media isn't reality on any side of it.
It feels like dogs in a dogfight pen.
Correct. Like it is designed to make you continually tune in. You know the rabbit hole? Yeah. All of it. TV is that. A lot of stuff that comes at you is that. And it's designed for you to want more of it because it supports your viewpoint. I said RFK in this room and someone was like, oh my God. And the other's like, yeah, rock and roll. Neither one is right. There's some things that, like me, I told you, there's some things that I absolutely agree with. Here are the things. There are some things, evidence-based, that I disagree with as a nurse. Here they are, right? Just a couple of things of it. It is not all good, bad, whatever. So in order to navigate this political system, again, you have to be in control of you. You have to learn to breathe. And in order to allow room and space for breathing, for learning, right? And you have to breathe in order to learn. You have to disconnect, right? And find some peace. Look at the trees. Go twirl in the rain. You know that lady on TV that twirls in the hills, and you're like, oh, she's so peaceful and so happy. And then it's like, this is because she took this. Buy our pill. So, again, it's learn what's in your control. You are in your control. Your emotions are in your control. Like stewing on something for more than a second is not useful. It is useful to let you know you may have an issue with it and you disagree, but continue spiraling into that rabbit hole because you have an issue with it. Nothing is going to change. All you're going to do is raise your blood pressure, constrict your vessels, right? Not breathe, not get enough oxygen into you, and be less effective as a human being, as a learner, as whatever. So that is the navigation of it. That's step one. Influence now. How do you influence things? You cannot change the system single-handedly. Nobody can. How do you influence it? You lead by example, yes. What else?
Oh, just spreading the word.
You spread the word. You use evidence and you spread it. You ask questions about it, right? So there's all sorts of things then that's in your control to influence. Long time ago, this, what you're experiencing today is by design. And not today being in this workshop, and I've been running this workshop for 13 years. Not since I founded the company. Not by accident. I have been passionate about health. My mom was very, very ill when I was 5. She clinically died twice. She had encephalitis. And back in the 70s, very early 70s, difficult thing to treat back where I come from. And so she was disabled for quite a while. And my grandmother and me ended up being the primary caregivers to her and help mom with this. And she was relearning stuff and doing things. And I was for several years, I was caring for my mom. And then as she started getting better, the one thing early on in my life I realized how important health is. I saw as she started to get better, I saw what it did for me. I wasn't as scared anymore as a kid of losing my mom, right? And I saw what it did for for us as a family. And so I became passionate about it. And I have been driving that forward my entire life, influencing. There's only so much that I can do, Mikhail, can do myself. But I'm doing it. I'm doing it today with you right now. I'm inviting you into this. And letting you know that you are not powerless in this. But you have to know your stuff. You have to learn your stuff. You have to use evidence, actual evidence, and not sort of like what you heard somewhere. And you have to make your own conclusions and decisions, not let somebody put it there for you. Because none of it is what it seems or what you're being told it is. None of it. So that's, I mean, it's a long, really long answer, and we'll get to some like more practical things yet and how to influence, but that's what I invite you to do. There was another question, Brianne.
Yes. As a nurse, how are we supposed to deal with such a wide, ineffective, and not so friendly, corrupted healthcare system?
Ineffective, unfriendly, corrupt, all of this. Yeah, it's like, look, it's design, right? We all are, and the answer is kind of the same, right? Remember that thing where, like, my mom as a patient, to her primary care physician, she said, I was like, she should look at herself, for she tells me to lose weight. I'm like, Mom! But again, as I said, she had a point. So modeling something is important. If you walk in the room and you reek of cigarettes, and you working with a cardio patient who smokes, and you tell them, don't do it. They're like, girl, you're kidding. So this do as I say, not what I do, hasn't been very effective for us as nurses. Right? So we actually get it. We have the science behind it of why smoking is like not that great. And all the sorts of things it leads to, but we're optimistic, right? We're like, oh, that horrible picture on the pack. That's not going to happen to me. And now, all the colorful things. And, you know, it's like the you know that thing, the mother of the dragons that some of you do, like. Like, that ain't smoking, that's peach. Without really understanding or recognizing what it could do, right? But before you can start being effective with somebody else, you have to go through that experience. And me, I smoked from the age of 12 to 27. I smoked for 15 years. My mom smoked. I was like, and she was like, don't do it, baby. I'm like, girl. What do you mean? And then, yeah, and going through the experience of quitting and all of this, I'm much more effective if I actually have to deal with a patient to guide them and facilitate their journey out of that addiction. I could be very effective. I have an experience with it, right? So using that, right? Not just like doing anything and going through it yourself. You become that much more skilled in doing something. And if you never smoke, do not start and then quit just to be able to be effective, just to be able to be effective with it. So look, we have to. We'll talk about this, but. Oh, sorry, yes, hi.
Hi, so you know the phrase,
nurses they're young, yeah, I know that phrase, and it's not just a phrase. I mean, they don't literally, like, serve you on a platter and like, delicious. Fresh meat, Yeah. Okay. Great question. I understand, right, that you can influence, after you get in somewhere, you can influence in changing that system. But if it's not good to begin with, right, and you got in there, and people are stressed out, like we've discussed this. As shortage improves, I think there's maybe less of this, right? Learn some power skills. They also are called soft skills. Communication, right? You have to learn resiliency, meaning you have to, whatever it is that comes at you, and practice with, TV, whatever it is that comes at you, you acknowledge that it came, you take a breath, you center, you ground, and then you approach and you use your communication skills and interpersonal relationship skills that you learn during the program to use that. You use your de-escalation skills, right? With somebody, when somebody is spinning out, contributing to that, again, pouring that gasoline on the fire doesn't work. It's just like both of you gonna spin out, right? And you, because you don't have seniority or anything like that, you're gonna throw your hands up and it's like, I didn't sign up for this, bye. I'm leaving this profession. 33%, this is a recent study, of all new grads licensed new grads, leave the profession in the United States within the first 2 years. Leave. But which tells me this, while you were in school, nobody talked about resiliency. Nobody talked about building it, right? Nobody talked about the soft skills that you must have, problem solve, and all of this. And at the end of the day, you have to know your stuff. You have to be competent. You have to be confident, you have to be compassionate. And understanding that whoever the environment is created by, in that environment, they are human beings. And it's very difficult, right? It's sort of, imagine this, a patient having a very bad day, and they're screaming, and because they're in pain, and they're demanding and all of this, and you go like, no! I'll come back when your behavior improves. Bye. Preposterous. Obviously you have to deploy some skills that you have in order to, and some caring and compassion and empathy and all of this, understanding where they are, and in order to deal with it. Same with your coworkers. It's the same thing. It's a human being. They are a human being. They're not having a good day. And they're just showing up that way, right? So again, can you control them? No. Can you influence them? Absolutely. Learn the skills. Learn the skills. And then, after you embed it in that system, start changing the system. Start teaching others about it, right? And inviting others into better culture and all of this. Healthcare culture is toxic. But it is the result of, it's not that they're bad human beings. It's the result of the system. It's the result of the shortages that exist. That we have been experiencing that in the system for decades. For decades, we cannot catch a breath. And so again, and start changing the systems that put barriers to development of nurses. Start changing that. Again, I said earlier, get involved in the political process to drive that forward. Yes?
Yeah, as a follow-up to reasons why senior grads live in the profession. So I've often had this statement that the award against your word, the patient's word against your word. So I also feel for nurses, there is not hearing sometimes when issue comes up. So I feel that will also be part of the reason. So I'm going to ask, is there supposed to be a kind of way to balance up, that kind of a statement that the patient's word against the word, even when you know that you're not actually wrong. Yeah. But I've seen cases where patients, says stuff about a nurse, which is not true.
Right. It is difficult. I mean, interpersonal relationships, right? Look, all humans suffer from one thing. It's called the human condition. And nobody yet figured out how to, treat that, the human conditions. There are some approaches to it. And again, you'll learn, right? So pay attention in your simulation when you get to simulation, right, and to virtual simulation, because you will be put in a scenarios where you deal with a difficult patient, right? You have to, and there's a lot of noise that's happening around you, right? It's not it's way more realistic of an environment rather than watching a mannequin on a bed and somebody doing something to it, like inserting a catheter. Those are not the skills that you're developing. You're developing clinical reasoning, and you're developing the power skills to sort of to deal with the situations like that. Without knowing the precise scenario and environment and how the policies of an institution work, it's very difficult to answer and kind of like your word versus my word, whatever. But again, as you engage with the patient, making sure that you're showing up with empathy, you're showing up with compassion, you understanding things, and there's only so much that you can do, but the things that are in your control, do it. Yeah. All right. Good questions. So, factors affecting poor health outcomes. We've talked through some of them. So there's social, economic, environmental at first. The first one is systemic inequities, generational poverty. So intragenerational poverty. We talked about it early in the broadcast of people from lower incomes, right, affording good food or doing other things or accessing care. I mean, it's really, 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 really difficult. It's virtually impossible. And so yeah, can you single-handedly change systemic inequities? No. Can you? What can you do? The what?
Influence.
Influence how? I mean, that's a nice word, but like, what is it like? There's something has to be behind it. Like, what do you do?
Proactive and show up. And be proactive.
Show up, yeah.
In your immediate area.
Go ahead.
Maybe some community outreach?
Community outreach, absolutely. Again, that edamame example, right? Like anybody can do it, but we have to get involved. We have to get involved with whatever we can, and doing whatever it is we can to educate and so forth. Again, as I said, right, my answer to that is this. And I've been at it and working on this for a very, very long time, my entire career, and then 20 years in education now. This is my answer to systemic inequity, to breaking intergenerational poverty, to allowing people like me who come here, to seek a better life, to actually be able to do it, right? And this, for the most of you, I can tell you this: the traditional nursing education system is not available to you because you did not go to the right school. You did not get the right GPA. And the traditional system says you're not worthy. Wow. This guy says, absolutely you are. And you can do it. And we've built the system that helps you do that. And then for some of you, break an intergenerational poverty cycle in your family. And get your family to middle class, right? And then be able to enjoy life better and all of this, and not work 25 different jobs to make the ends meet, right? So that's in my power. When you and look, I told you, like, if I can do it, nothing like particularly special about me. I'm just resilient, right? I just learned those power skills early on. To push through and push through and push through, push through my fear, push through failure, and I failed quite a bit. Do you imagine like proposing this initially to the U.S. Department of Education or any accreditors? They're like, oh, no. That's not how we do it. It's never going to work. Nope. Well, tell the 7,000 plus learners that we have across the country and thousands of graduates that it doesn't, and licensees that it doesn't work. Right? So, but it's like, it requires, nobody will tell you yes on the first attempt. Nope. You have to go at it again, and you have to get more evidence. You have to learn more. You have to, I mean, like all of that stuff in order to do that. You can influence. You can contribute. Your career can navigate and can do, so you can do a lot of things. Social isolation, loneliness. I do have some like an interesting stat on that while you're thinking what it is that you can do. It is loneliness. Living in isolation reduces our chances of survival, and social isolation increases the risk for premature mortality by 29%. This is a 2015 study. 29% higher chance of dying because somebody lives in isolation. You know how many older folks live in isolation? You know how many teenagers live in isolation, although they're constantly think they're connected? This is not social. This does nothing for social wellness, which is one of the multidimensional wellness things. Poor social relationships, social isolation, and loneliness, that's another study, can increase your risk of heart disease by 29%, risk of stroke by 32%, a 2016 study. Smaller social network size is associated with an increased risk of type 2 diabetes and of other diabetic complications, including heart attacks and kidney disease, 2017 and 2018 studies. Among older adults, chronic loneliness and social isolation can increase the risk of developing dementia by 50%. 2021 study. Being more socially connected can improve stress responses and minimize the negative health effects of stress. Social isolation, or even the perception of isolation, can increase inflammation in the body to the same degree as physical inactivity. Ooh, do we talk about like all that in places and educate people around it? Absolutely not. So, and again, the what can you do? What can you do? Create community, yes. You have a great community here. I hear there's a social mixer at 6 p.m. here. Sorry, everybody in the cyberspace. I was like, you weren't invited. Now some people invited themselves to this party, so like that's great. That's fantastic. But yeah, like you can create, right? Worry not, when you talk about systems, worry not about the scale of change. Worry about change. If you made a difference with one person, that's positive outcome, that's change, right? And then as you improve your skills, as you improve your engagement, as you sort of progress in your career, then you will be able to influence and affect more. Understand? But never, I was like, look, it's like, end game is world domination. Health for everybody and like education for everybody. Ta-da. I know, right? But that's kind of a large scale to think about. So you do one person at a time. You do one thing at a time. And you can drive systems change through that. Climate change, read up on it. There's several pieces that have been published and studies that have been published by American Nurses Association, so by nursing organizations in the last few years that say climate change is a health issue. It is a health issue. Hear of those like tornadoes and all the events that's happened. Does that affect health? Very much so. So it is and it's like, oh, what do nurses have to do with it? What can you do with it? With this information? Educate, what else? You start making better choices yourself. Like, again, what is in your control? What is in your influence? You have to differentiate those two things and kind of make a better choices. I've given up eating meat some time ago, about 7 years ago, because, but better for my health, certainly, and also, not as many farts are generated by cows that have to, you know, yeah, like, that have to die for me to eat them. And not, you know, like, I don't have a particularly, like, sort of take on a, like, oh, poor animals, like, like, whatever. But I know what's good for health, and I know what's good for the environment. And so, ta-da. My thing, right? Gun violence. I read that statistic for you. It is 10 to 19 years old, mostly very prevalent in the Hispanic and Black male communities. Now, unconscionable. And yet, you know, what can nurses do? Advocate. Advocate for gun control. Because when somebody, and I have seen it in my, like I did a short stint in an emergency room a long time ago, and getting somebody with a gunshot, and I was around triage, and wow. Shortly thereafter, I can't, right? Like I couldn't do that myself, but so in dialysis, yay, old people. And chronic conditions. But anyway, so that's okay. Population behavioral lifestyles, inadequate health promotion. We've talked about it quite a bit, right? Who's going to promote it? You, right? With whom? Patients. Whom else? Family. Anybody you could, like your 523 friends on Facebook. Do it. It's like, I don't get it, but hey, I mean, more power to you. But yes, you would think we'd be the healthiest country in the world because we have, more than 1% of our population are nurses, and then everybody has a bunch of friends, and you're like, oh, it should be easy, right? And like, oh, hey, I'll do it with my group. Do it. Do it. Don't wait for somebody else. Again, for as long as you cross your sort of like, or do a wishing bone or whatever it is you do, the change is not going to happen. You have to take and do what's in your control and drive it forward. Promoting health is in your control. With you, with your family, with your community, with your circle of friends, should be your job. Not because somebody's paying you for that job, but because you actually care to change some things and to systemically change the outcomes. So that's important. Poor nutrition, lack of exercise. I mean, it's like some evolutionary scientists are saying, like, at some point, we will grow like this bone right here a little longer to help us keep it down. Yeah. I mean, like, because that's our favorite position now. Just pay attention to yourself. How often you're like, every waking moment when you're not doing something else, and it becomes more and more and more. So, and lack of exercise, yeah. Preventable, poorly managed chronic conditions, yeah. Go ahead.
Lack of exercise, I live in Lincoln, and I went to a board meeting recently, just one, and he was saying that there is talk, somebody is trying to get like a little 3-mile running trail
walking
through
trail
our area, and it never even occurred to me, oh yeah, we don't have to drive to Sacramento if we want to do stuff like that, and it never occurred to me to speak up and promote something like that in your own little community, like, hey,
correct.
Like, shut down the roads, get people involved.
Go to your town hall meetings. Come up with stuff, right? Look at others. There's examples of good stuff, right? Everywhere. It exists. Evidence exists on how to do it. Evidence exists in like many countries in Western Europe. Wow, they figured some stuff out like some time ago. Not, and that's part of the contribution of why they're doing better health outcomes and spending less is because they do stuff. We're a little late to the game, but you can. Yes?
I guess going off of that a little bit, I think a big part of it is just self-awareness. So
Yes.
one of the things that I actually learned recently that doesn't really get taught is it's about poor nutrition, what you can and cannot buy on an EBT card.
Right.
Which is really interesting because you can buy a lot of candies, you can buy a lot of junk food, but you can't buy a lot of meals or like other healthy foods because it's considered a luxury item.
Yeah, exactly. Luxury item. Ooh. Right. Candy for all. It's like, you know, EBT is like Oprah. You get candy and you get, everybody gets candy. It's true, but policy change, right? Like we're talking quite a bit today about policy change. It doesn't happen just when you sit and wait for it to happen. You have to, you have to get involved. You have to position yourself in a way through learning. A lot of it is through learning, and then advocating and showing up and doing it in a way that will allow you to be heard in the communities, in the state, in whatever it is. And what I suggest is this: look, you can take any one of these things and spend your entire life and career, for sure, driving that one thing forward. Figure out what you're passionate about, right? Figure out and why you're passionate about it. I mean, you pick this profession, yeah, like it is a ticket to a better life, that license. But it's a very tough way to like do it. So you have something, obviously something brought you here that is beyond just that goal, right? And then what? And then what you do with it? And what are you going to drive forward? One thing, just pick one. Do better yourself right now, and then become better. Learn from it and become better in guiding others. Reactive rather than proactive system, right? So we have a non-system because the coordination and all of those things that we described. And also, sorry, I have to stay behind the line. And also, again, we're like what the system that we've designed that is focused on acute care treatment more than anything else is not serving us well. It served us well in the 1950s. We are in 60s. We're a long way away from that. Most of what we experience is chronic conditions. Our system absolutely is not set up to prevent those and then to truly manage those when they're there. What can you do about that? Turn off Grey's Anatomy or other whatever's on TV today, and stop thinking McDreamies or whatever they are, and like the glamour of the drip, 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 because it's so sexy. It is. And like, I see you work and all of this. And look, and we need some of it, right? Most of you should focus and direct your energy toward community settings, toward long-term settings, toward rehab settings. This is where it happens. Home health, so forth. I talked about it. I know it's not as sexy, but that's where the need is. And if everybody's like, NICU, I used to do the new learner welcome forums. And I would ask the question, and like half of the room would be like, NICU. I'm going into NICU. Sick poor babies. I'm going to work with them. I was like, no. I mean, no. Nobody's going to hire you in NICU to begin with. But then, and for some of you, obviously, it could be you're maybe passionate about it and you're going into it for the right reason. But most of you, again, focus on how you learn and what you do. If you want this change in the system, you have to apply yourself in a way that will drive that forward, right? And look, I was like, oh my God, someone was like, oh, my dreams are crushing. Oh, here's Mikhail. Here's I thought, drip, drip, drip. and he wants me to do what? I'm like, yeah, because it will, if you do, over time, the care will become more effective and will become cheaper. and it's going to be good for all of us, our entire nation, all communities, when the focus moves away from acute care and really is placed where it should be. So I don't know what RFK is like sort of thinking, or what HRSA is going to be doing about it and how they will be changing these policies. But this EBT thing that you're talking about, did you hear that the soda somehow now is being taken out of the equation? And so, like, yeah, like sugar. Soda, like carbonated water, sugar water. I mean, Coca-Cola wants you to think it's happiness. Their latest is like, oh, it's magic. Or whatever the commercial says nowadays. Oh, Coca-Cola is community. It's not. It's, you know, carbonated, chemical-ridden, like sugar water. Yay. Don't sue me, Coca-Cola. Anyway, you know, changing this system that and forwarding to what that disengaged financial sponsors, employers pay. We pay. We already determined, right? 75% you're sponsoring of those trillions, and we pay, and we're like, okay, here it is, signing the check. We're not even seeing it if it comes out of your paycheck, right? And yet nobody, most, do your employers where you work today, do they promote wellness? Do they invest into wellness? Do they, you know, we do quite a bit. Multidimensional wellness, not just physical, emotional, and mental, which is like the three, you know, bottom lines. Social, occupational, financial, all of this stuff. Here's what we did on the wellness side and supporting the health of our collaborators side some time ago. So there's a couple of new policies. Last summer, we introduced a minimum pay of $25 for anybody who works at Nightingale in any role. Minimally, if the market doesn't pay them that, they get paid that. Okay. So there's like, oh, I want a job. I want a job at Nightingale. Hey. Like, show me what you got, and you may get a job. And also, we just introduced paid parental leave for our collaborators, right? So paid parental leave. Now, these conversations have been happening politically for how long? Ever. We should have it. We should have it. Somebody should pay for it. What it's going to take is you getting in the positions where you say, hey, and for my organization, we're going to have it. And the people that were, again, it's not, grassroots change matters. And what you do matters. And how you're engaged matters. So inability to access care, we talked about that. Provider shortages, what's yours to do here? Come on. What are you going to do with provider shortages? Become a nurse. Ta-da! Not throw your hands up in the air the first time you fail something. Like, that's it. Too hard. Or worse yet, I'm too dumb. You're not. You just have to apply differently. You have to delete those apps. and then, you know, you'll do better. But yes, that's what it's going to take. And advocating for policy change that removes barriers for people to become nurses in this country. Oh. Where do I start? I mean, we can start at the top, but what can you do? What can you do? I mean, a lot of it we've already talked about. Anything else? Anything else on this? What can you do? Litigious means we, you know, like we like suing things. We have many lawyers. That's a popular profession. Yeah. Hey. I mean, you know, it's like, got to support all the lawyers we have, and therefore, So we're litigious. That's why part of our cost problem is that, because we pay higher prices because providers, and again, and it's really easy, right, to sue a provider because it's in a system and a shortage and all of this. It's really easy. It's human. Making mistakes is human. Right, making errors is human, but when you're under so much pressure and such an incredible shortage, it happens more often than not, and then contributes to part of the, and then the lawsuits and all of that, and it contributes to part of the system. There's a well-publicized case about 2 years ago, or 3 years maybe now, like time escapes me, but on a nurse that was criminally charged with making an error, and it's administering a wrong medication and essentially killing a patient, and she was working her second consecutive shift, no break, so she was on the 14th hour or 15th hour of work or something like that, and short and trying to get to many things and all of this, and so so yeah, do we again? I mean, the shortage, don't think that the shortage is just something that sort of like, oh yeah, like we talk about. It affects absolutely everything in spending and outcomes and all of this. And again, and yours, I'm inviting you, those of you in California, advocate. Advocate with your elected officials in your community, your assembly people, your senators, your governor. Advocate for it. It is not going to change unless the people's voice is heard. And going to the ballot box every couple of years is not using your voice. It's like the bare minimum that you can do. And to the outcomes that it leads to. So lack of care coordination, unnecessary diagnostics, overprescribing, all goes to provider shortage. A lot of this. Administrative costs, we discussed that. People. Repeat after me. I will promote health.
I will promote health.
I will work on preventing disease.
I will work on preventing disease.
Very good. And I will dedicate myself to effective chronic conditions management.
I will dedicate myself to effective chronic conditions management.
Awesome. This is what's needed, and I know, again, I know it's probably I may be deflating some of you because it's like, oh my God, that's not what I want to do. But what you want to do and what's actually needed may be different things, and so please, I mean, my hope is those of you in the room and folks out there in the cyberspace that you choose. You choose community settings, you choose long-term settings, you choose rehab settings, subacute settings, home settings, telehealth settings. I mean, you choose that as your area of practice when you get licensed, right? Because it's needed. It's sorely needed. And I'm sure there's going to be, I said, I don't know what RFK is going to do, but I can almost bet you that there's going to be a bigger investment in creating practitioners that do this, right? So if you commit, there may be right now, if you go to a rural area, there's some federal programs that repay loans for nurses. If you go into really acutely short areas and work there, but you have to, go to the middle of Alaska or other places. But I'm sure more programs will come that focus practice on these things. Right, and give you loan breaks and whatever else that to do this. Shortage and consumers, right? We talked about no comparative shopping. We're overly optimistic. That's not going to happen to me. That's scary pictures for somebody else. I'm much luckier than that. Yeah, as a society, we're very overly optimistic. And then our sedentary lifestyles is that. All right, so we have a few minutes left to, and I'm going to see if there's more comments, questions in the cyberspace, and but it's discussion now. Okay, see my email there? Okay, here's what to do with the email. It's like, hey, Mikhail, I think I want to show up at a community meeting in my community, and I want to promote this. And here's what I'm thinking. But do you have any pointers for me to how to better say it and whatever? And I'll be like, great, fantastic question. Let's ponder. Let's discuss. Let me maybe coach you a little bit more on this. Now, if everybody emails me at the same time, you're going to be waiting for a while. But I'll get to you. Now, this is what not to email me with. Hey, Mikhail, I don't like my grade. Can you tell your people to change my grades? Here's my response. I thank you for reaching out. I understand that you may be frustrated or experiencing some feelings around the grade. Unfortunately, or actually fortunately, the federal regulations prohibit me from getting involved in any individual learner's academic matters. The end. Good luck when you try it again. Put, turn off TikTok or whatnot, and dedicate more study to learn. I mean, more time to learning. Yeah, and sort of I cannot do your placements. I'm powerless. We have people that do things that, and if they're telling you this is how it must be, I have no such power to override, their decisions. I'm not the magic gnome, just, so that you know. Yes?
So when we start doing our traveling, and I'm on Facebook, and I follow everybody's like, hey, I'm going here. Is anybody else going? Does the school have a central place for us to a carpool thing?
I think there is something like that. There's some portal that was just released in 1.0 version. There's a 2.0 coming. Again, I'm not technical things of how it works. I'm not a good answer, but I'm pretty sure I know people organize somehow, and it has something to do with the learner portal. But that's beyond. And then, but I can pose that question to Bree, to the people that may know, and then I mean not Brienne, but somebody, and we'll get the answer out to all of you on that, whether there is a central place to meet up and carpool and do things and whatever when you have to travel. Okay, not kind of sort of good. That's good discussion. I want us to give me some questions, give me some thoughts about what we talked about today, and your involvement in it, your engagement in it, what did you learn, what do you think you can do? Yes.
So
sorry,
you're good. I'm just signing up as a volunteer doula because my goal is to be midwife. So
awesome.
Midwife, and I'm big on
babies are awesome.
Well, I'm big on lactation because I feel like it's just broken.
Yeah.
But as a doula, I'm so limited on what I'm allowed to say, what I'm allowed to do because providers rule. And at this particular hospital, the stats are still about 80% of women giving birth on their backs, which is pretty high for a position that's not super great for giving birth.
Yeah.
So something I was thinking about bringing up, and I was not sure how to approach, is you can give birth on your back and roll 2 towels on either side, and then your sacrum has room to move.
Right.
And so it's this very small change that could make a big outcome in women's ability to push the baby out.
You know so much more than I do on that topic.
Here's the thing that you'll probably know more is I don't know a good way to approach the providers because I'm not trying to take away.
Right. So again, your best friend in anything that you try to change is actual empirical evidence. So you go through journals, right? You all have access to a gazillion things in the library, in the digital library of articles and evidence and like from peer-reviewed studies. So peer-reviewed, remember this phrase, peer-reviewed evidence is your best friend when you're trying to drive a change, whatever change it may be, right? And if somebody, for example, I'll give you mine, and so when I first started working in nursing education 20 years ago, I asked a question at the Board of Nursing meeting, and I said, hey, I know nothing about it. You know, I was new in it. I literally knew nothing about it. I was a nurse, right, and a manager prior to that in the services. Why is it so important for the graduates of programs to pass the licensing exam on the first attempt? Here's was the answer. It's a good thing, and it's in the interest of public protection. And I said, oh, that's interesting. Like, what evidence are you basing this on? Like, what, can I read something about it? What is it? No! This is how we do it. This is what we do. Stick with it. Give a boy a challenge. For 20 years now, it's like, okay, if it's not a good thing. Guess who did not pass NCLEX on the first attempt? This guy. Did not. Yeah? So I was like, what a dummy. I'm not good at standardized tests. I'm not a dummy. So for 20 years, I was like, I am going to change that. No evidence exists. No peer-reviewed study exists. I am going to produce it. Oof, long way to it. Like convincing somebody to invest in a school that I want to build. Grow that school. Get thousands and thousands and thousands and thousands of data points into it. And this, so I'm presenting the data for the first time at the Nursing Education Research Conference here in a couple of weeks in DC. First evidence of its kind, seminal work, and then we're going to publish, and it's been peer reviewed, and we're going to publish. We're still not sure which journal, but we're publishing, right? So when it doesn't exist, like you make it happen, and what that says that not only that there is no literature, no evidence that supports that policy, what it does is prevents people from low socioeconomics from accessing the profession. Like that is the conclusion, that is the thing, and it is it's going to be the first study of its kind, and then other people will, we're inviting others then to do more research on it and follow it and drive it forward and change it across the country, because that is one of the huge barriers that exists to access and to getting more people into the profession. How many of you have gone to school and then had to leave because you were not a good test taker? And they like there's several that come to us that say, I was admitted in another school and they told me I was a dummy because I couldn't pass on the first attempt, or I didn't pass the predictor test, and they withdrew me one semester before graduation. Like that happens. So, sir, you have did you have something? I thought you were, yeah.
Sorry to cut this. At the beginning of this second section, you made mention of first and second license.
Oh, okay. So multi-licensure. That's why we don't really know how many nurses we have, is because each state counts their licensees separately. Right, and not all states participate in the compact system and nurses system, which does give us a better idea of how many individuals are there. But so the number of licenses is over. When you're talking on a state level, every state thinks they have more licensees than they actually do, because some people travel into the state as a traveler for 3 months and get a license, and then they continue keeping the license. I'm licensed in California still. I'm licensed in Utah under multi-state compact. So both Utah and California will count me as a licensee, although I'm not actively practicing at all, right? And so it's difficult to pinpoint what the real size of the problem, and that's why all of the studies oh, it's anywhere between 250,000 and 1 million. that we're short. So yeah, again, systemic issue that needs to be solved, and I'm trying to educate people on the Capitol Hill in Washington and Capitol Hills in some states like here to really have how to go about it and really think about the issue in a way that actually makes mathematical sense. So that's that. Yes.
Speaking of Capitol Hill.
Capitol Hill, yeah, we love Capitol Hill.
So with the current presidential administration, has Nightingale been impacted at all with the new administration changes and the new head of the Department of Education being the wife of WWE CEO? Is there anything that's going to be impacting students in the coming years?
Yeah. I chosen, just so all you know, I chosen a sector, for-profit education sector, that many in Congress think, especially on the Democratic side, think should not exist. And based on that, right, so they don't care that for you all, it may be the only option that you have to go to Nightingale as a choice for nursing. And there has been a concerted effort over ever since I've been working in education for the last 20 years to kill this sector, to destroy the company that we have. And so what's happening now, as a matter of fact, some of the onerous stuff that makes absolutely no sense, sort of like first-time pass rates. There's some federal policies that exist that are nonsensical, have no evidence behind them, and yet, are touted as a good thing. So some of that stuff is going to go away. And so so on balance, for you all and for Nightingale, it's, time will show, but on balance, it seems that we're going to actually come out of it in a better shape and have less barriers to be able to produce nurses in the United States than we had before. So that's, again, but I know, the scary stuff on TV. Breathe through it, look at the negative spaces, ask what else can be true about it. All right, I'm going to finish with this. Look, thank you all for coming. Thank you all for tuning in over there. I look around the room, and what I experience is optimism and hope, and that you all are going to change the system that so needs to change by what you can control and doing what you can control and influencing other things. I thank you so much. You are the future of it. Stay for a quick announcement here in the room because Brianne asked for it. But other than that, again, the future, look at you all. The future is bright, and thank you so much. And flame forward, everybody. Thank you.